Okay, Doc, next question. Hi, Dave. Love the Ask the Doc series on YouTube. I am 46 years old of age, 6'4", 240 pounds, around 15% body fat. I've always been a hard gainer, and my gains have always been slow and steady. I've been natural my whole life until now. My cycle is test and take 600 megs every week with an addition of tren acetate at 300 megs per week and EQ at 600 megs per week for a 12-week cycle. My gains are great, and I have gained 10 pounds with decreased fat and more muscle. My question is the following. Do I need to worry about PCT if I am on TRT for life with the doctor's prescription? 10 days after my cycle, I have kept all my gains. I top up my doctor's RX with 150 milligrams of test enantate a week for a total of 400 milligrams per week of test enantate. That's it.
Well, that's an easy one. Yeah, I mean, you definitely, what is the purpose of cycling? When you're in your 20s, it's to preserve testicular function. Or any time, it's to preserve testicular function. But what's the point of trying to, don't shoot the messenger here, but at age, what age?
46, I think.
46 or 48. What natural production is there to preserve, more than likely, okay? So do you need PCT? No. The only reason for...
I think it's a myth, though. People just assume that this is something they got to do. It's like gym.
Well, even if you're 25, yeah.
Yeah.
You want to know the fastest way to get your testicles up and running again? Go cold turkey. Because after a few weeks, depending on what you've done and for how long, typically I find it's about 3 weeks if someone's been on a standard replacement therapy dose. The pituitary is going to start screaming at those testicles, hey, do something, pal. And then what I find is the main reason for what they call post-cycle therapy, which for me means just get something to stimulate the testicles and block the production of estrogen. I typically use ACG and anastrozole for that, is, excuse me, what was I saying? Sorry.
You were talking about the reason why you take ACG and ACG and anastrozole when you're 25, in between cycle or post-cycle therapy you were talking about.
Oh, well, but yeah, I was saying that the reason is to get them up and running again, but the fastest way to do that, the most efficient, if you will, is just to go cold turkey because, as I said, after about 3 weeks, typically your pituitary will start screaming, with some LH at the testicles to start functioning again. And it'll happen very quickly that way. The problem is it's not very comfortable. And of course, for a bodybuilder, they're worried about the gains that they'll lose during that period where the testosterone is very low.
Right.
Which that part is a myth because, here's a mistake a lot of people make. You're on a cycle of something anabolic, okay, and you start to worry about, okay, how am I going to hold the strength? How am I going to hold the muscle gains, period, any of the gains? And it's typical human nature, I guess, to say, okay, well, at this point, I'm coming off this stuff. I'm going to have to train twice as hard now, do twice as much to hold the gains. When in fact, that's the worst thing you can do. Why? You just stop the one thing that was giving you the advantage, the anabolic advantage, the recovery ability. So now you're going to overtrain?
Yeah.
How is that going to get you anywhere? And people usually wreck themselves after they come off and they blame it on, and it really sort of brings this whole thing to the fore about being dependent. Look, we all know that these things are very, very valuable. They're very useful. They do it with what they're intended to do. But dependent, no. If instead you cut your workouts in half or do whatever it takes to keep the balance so you're not overtraining, you'll hold that just like anybody would, right?
That's great advice.
So
a lot of people fall into that trap, yeah.
Well, and it's for good reason, man. Hey, work harder, go for it. I get all that. But, you got to engage the noodle and say, okay, what's the smarter way of doing this? And try and hold the gains. So in this gentleman's case, at 46, you definitely want to cycle off of the anabolics because, as we know, all anabolics, and it's rare I can say this, all anabolic steroids are going to negatively affect your lipid profile, right? It typically is going to lower your HDL, the so-called good, and raise your LDL, the so-called bad. So even though we know why it's happening, well, you're using anabolic steroids, so you're going to see those numbers change. And it's not pathological per se. Well, eventually, if you never go off, then it's the same thing as being pathological. It's pathological steroid abuse, if you will, that's causing this lipid profile, dyslipidemia, we call it. Now, that opens up a whole nother can of worms. I've talked about lipids before and how, just because you have a bad lipid profile, as long as you don't have established coronary artery disease, it doesn't mean you're going to get it. Okay, the problem, the culprit in all this is not the cholesterol. This isn't ringing a bell. I haven't talked about this before.
No, you have, yeah.
Oh, okay. So,
But we should reiterate.
Well, just in brief, I mean, it's been very logical since roughly the 70s that we said, okay, you got coronary artery disease, let's fight it, if you will, logically by getting rid of all the building materials for plaque, cholesterol, right, or the main one. It is very logical, but by the same token, if you want to get rid of motor vehicle accidents, what are you going to get rid of all the motor vehicles? That would be logical, but it's also, you're laughing, irrational, right?
Yeah.
And by the reverse analogy, if I were to dump a bunch of building materials on your front lawn tonight, would you expect a guest house to erect itself over the next 3 months? No, it requires a contractor, right? Ditto for cholesterol. The building materials themselves aren't going to become plaque. It's with inflammation, the building contractor in this case, that you have a problem. Now, I quote my favorite, or one of my favorite, because there's two of them over there, cardiologists, by saying, the page on the web that says that once you have established coronary artery disease, a statin won't help, or reducing your cholesterol won't help, is right next to the page that says that no Jews were killed by Nazis in World War II. Okay, it definitely can, by reducing cholesterol, it definitely can halt or reverse even plaque formation. So how do we get way off on cholesterol? Oh, just about the reason for coming off and not staying on it all the time. And it ties into the fact that he's on a testosterone replacement therapy dose already means, well, with post-psychotherapy, what are we really doing here? Yes, we're getting off of the anabolics, but that's not really what most people mean by post-psychotherapy. They mean, hey, let's get the old function up and running again. In this case, that's unnecessary. So yes, post-psychotherapy in someone who's already on testosterone replacement therapy for life all year round is nonsensical, right? What are you doing? You're coming back to something that replaces your endogenous production. So why are you trying to create your endogenous production
So
again?
you don't believe that by adding HCG to your exogenous, you don't get any better results?
Typically, no.
Okay.
How do you define results? Do you get more testosterone in your system? Somebody 46, highly unlikely. In other words, it's a drop in the bucket. Someone 25, yes, but then you wonder, why are you even bothering with some testosterone? If HCG is helping you with your endogenous production,
right,
why wouldn't you be able to just create enough endogenous production where you're okay? And then that begs the question, well, isn't there some line at which, at 30 something maybe, you can get something out of your endogenous production and something out of exogenous that adds up to? I'm sure, because I've seen it. I don't do it in my practice, but I've seen people come in with that sort of thing going on. But I think it's a very short, small window, if you will, where that happens. At some point, you got to be on one or the other, and mostly, the patients I deal with, where it's testosterone replacement therapy, the only reason for HCG results are for keeping the testicular function for not testosterone contribution, but fertility or cosmetics, preventing testicular atrophy.
Yeah.
So if that's what you mean by results. So I don't think I even got this guy's question yet. Sorry. Well, no, I did. Do I need to worry about PCT? No.
No. There you go.
Just go back to your new baseline standard
hormone replacement therapy.
Yeah,
TRT.
which is replacing your endogenous production is what I'm trying to say.
Very cool. Thanks, Doc.